So I'd like to call the meeting to order. We'll go ahead and start with introductions, and I'll go ahead and I guess start, and we'll work around the room to my right. So I'm Dr. Burley, EMS Medical Director for Monterey County EMS Agency.
Teresa Rios, EMS Director.
Jeff DeAndrea, Analyst, EMS Agency.
Deb Hopgood, Analyst, EMS Agency.
Kimberly Hernandez, EMS Analyst, EMS Agency.
If you want to,
Also, Steve Brooks, working remotely, EMS Agency.
Tina Nieto, law enforcement, via Zoom.
Scott Houchin.
Sorry, Scott.
Oh, that's okay. Scott Houchin, first responders.
Okay, Roxanne Seversad, EMS Agency.
Noah Hawthorne.
Jeff Warner, Air Ambulance Providers.
Is it Dr. Cole? He raised his hand? Yes. What is?
you can just activate your mic, Dr. Click, if you want to speak.
Oh, okay. All right. Call Click, Natividad.
Welcome.
Okay, there should be at least two more.
I think we have Dr. Kalinsky. Are you with us as well?
Yeah, sure.
Yeah, Michelle Kalinsky-Chomp.
Thank you. Welcome. Anyone else?
Dave Craddock, paramedic.
Thank you, Dave. Okay, well, welcome everyone, and we'll go ahead and get started with our meeting. We'll open up the meeting with an opportunity for public comment in which any member of the public may address the subcommittee for a period of not to exceed 3 minutes on any issue not on the subcommittee's agenda. Opportunity for public comment. What's that?
Nobody raised their hand.
Okay, so hearing none, we'll move on to the approval for the past MAC meeting minutes from November 5th.
Do roll call.
What's that?
Motion and then.
Yeah,
Yeah.
so we'll need a motion to approve.
This is Scott Houchin. I motion to approve.
Thank you, Scott. Do a second.
Jeff Warner, I'll second.
Who was that?
Who is the second?
Jeff Warner,
Okay, thank you, Jeff.
thank you.
And so all in favor?
We'll go in a roll call.
We'll do a roll call. So do you want, Estella, can we like move through the participants for a roll call
Yes.
for approval?
Yeah.
I don't have them in front of me. Are you able to do a roll call through for them?
Yeah.
Jeff Warner,
Aye.
Michelle Kalinsky,
Aye.
Scott Houchin,
Aye.
Cole Click,
Aye.
Tina Nieto,
Abstaining because I had logged in late due to technical difficulties.
Dave Craddock.
Aye.
Jeff Warner. Sorry if I repeat.
Aye, times two.
And William Hiller is also present. He says that his mic is not working.
William Horn.
Hiller.
Aye. I understood that.
Mhm.
So William, I think you just joined us. We're doing approval of past MAC meeting minutes, and we're just taking a roll call. So if you're in approval, if you could just say aye.
Looks like Will had indicated in the Q&A that his mic isn't working.
Okay. Oh, okay. And are there any nays? I think we covered everyone at the meeting, right?
That's all the members.
Okay. So that the meeting minutes from our past MAC meeting are therefore approved. And we'll move on to EMS recognition. I don't think we have anything specific this month and no specific correspondence, which brings us to old business. And the first item on old business is EMS agency response to COVID and the health department report regarding COVID vaccination.
We had invited Nick Steller from Public Health to give an update. Unfortunately, they scheduled clinics, vaccination clinics for this week, and he's unable to attend. He did send us the flyer that you see on the screen. Jeff DeAndrea from our team has been very active in the planning of the vaccine rollout. And so he'll give an update on Nick's behalf, and then he'll give additional information as far as the rollout. Please.
All right, hello, everybody. Let me take that off for a moment. So yes, I've been working with, is our camera here? I've been working with Nick Steller and other health department officials. Specifically, my role has kind of been just facilitating contact between fire and EMS. And this goes to our recurring conversations, Chief Nieto. As we wrap up fire and EMS, I'll be more involved with communicating with law enforcement as we move into that tier as well. Right now, we're, as Teresa mentioned, there's daily mass vax clinics that are still limited to phase 1A folks, tier 1. There are coordinated efforts with various agencies and whatnot, but there are also these mass vaccination clinics happening that are sort of catch-all opportunities for individuals in that tier to get vaccinated. And then I want to applaud Scott Houchin, because you're on the call here with us. Salinas Fire recently got approved for their LOSOP, so their paramedics can begin administering vaccines as well. So that's another step forward in the whole process. Do we have any particular questions regarding vaccines at this point?
Hey, Jeff, Scott here. Thanks for all your help in getting our LOSOP process through. As we look at tier 1A and moving to tier 1B, I know I've talked to Nick. I don't know if you have any more insight, but is there any timeline of when we might see this? The media's covered it pretty broadly as saying they're just going to start blowing out vaccines. And I don't know if you can give us any better guidance as to what the process may hold for us as we move forward.
Yeah, as far I know that I know that the plan is to not wait entirely for all of tier 1. And so let me back up and say that we all get the tier and phase thing confused a little bit. But tier 1 within phase 1A is pretty much, the majority of folks have been vaccinated. And I know that there is an intent to begin with tier 2 before every single individual. We don't want to delay it for every single tier 1 individual. But at the same time, we also don't want to rush into it so that there's a bunch of tier 2 people getting vaccinated before everybody in tier 1 gets vaccinated, as that can be provocative for some folks. As far as the exact proportion in the weeks to come of what we'll be seeing in the clinics, I really can't speak to that as far as numbers of tier 1 versus tier 2 folks. But I know that the plans are in place and the ball's rolling forward. At some point, I think it'll be probably just a few weeks before we're, the entire phase 1 is planned for, at least. And that's not necessarily vaccinated, but plans will be in place. The Friday planning group that you've been involved with, I want to encourage everybody that's open to any agency representative that wants to get involved in the planning on Fridays with Nick's team there. You can contact me if you want to invite Nick Steller or myself, and maybe is there a way to we can sort of put the Mohawk address up there largely. But it's mohawk@co.monterey.ca.us. If anybody on the call wants to get in touch and get connected with Nick to participate in the planning. So hope that answers a little bit there, Scott. Does that help at all?
Yeah, it does. I
Okay.
think we're looking more at the tier 1A and 1B rather than the phases. And you guys have done a really good job pushing this out, and the county is responding in short timeframes, which, I mean, the more lead time we get, the better operational compliance we can provide too.
Yeah, it's absolutely, I'm on board with that idea. The trick has been all along that the number of vaccines allocated is announced quite literally the week before. So that's the big trick, is it's really hard to plan not knowing if next week we're going to receive 1,500 doses or 2,500 doses or 1,100, or, so that's kind of the logistical challenge, is not knowing what next week holds for us.
I have a question from Ben Hitchcock.
Yes.
Is there a timeline for when the booster scheduling, AMR staff needs to begin the process of getting our boosters by the 23rd of this month?
Let me connect Ben and Nick on that, because I'm also not up on what scheduling took place, because Ben was involved. I don't know if you're listening, Ben, right now, but you and Nick had coordinated with the scheduling with Mike and Tino as well. So I don't know if that was included. It sounds like it wasn't, but if there was provisions made for dose number 2 in your guys' scheduling. All right, anything else question-wise?
Hey, this is Scott one more time. Just a last comment. Thank you guys, and I appreciate Jeff's hard work in this process. This has been herding cats on fire, smoking meth. So good job.
Thank you for the metaphor. I'll file that one. Shall we move on to?
Sounds good. Move on to Mohawk.
Okay. So let's see here. So on the Mohawk level, here's a little update of what we've been doing. We're at this point over 1,400 requests for PPE, primarily PPE and other products, have come through the Mohawk and EOC Logistics. And for the most part, we've fulfilled just about everything. Things are starting to get tight right now, I should add, just throwing it out there, with gloves in general. And that's a statewide problem that we're starting to see. We've also moved into a lot of my work now is involved with staffing requests. So we've got hospitals and skilled nursing facilities making staffing requests. This is can be a frustrating process for the facilities, because we're typically getting, somewhere in the ballpark of 10% of the staffing requested or so is allocated. Let's see here. We're also just mentioning the LOSOP again, working with Scott and Chief Vaughn. We've got Salinas Fire authorized for their paramedics to provide vaccinations, and we've got Monterey Fire on the same program. So Monterey Fire has been doing a great job, and I'm presently working with Hunter Liggett with their small team down there. But we think in the long run, they have an interest in general public vaccinations for South County. And given the traditional isolation of South County, we think that's going to be pretty valuable. We continue refining our IT process and the request and the data tracking and all the distribution reports for PPE. We keep handling swabs, testing kits. We've got Binax antigen testing kits, and the various lab materials that we got to keep flowing into our labs here. And we've added, since the last MAC meeting or EMCC meeting or ops meeting we've gotten into the business of distributing monoclonal antibody therapeutics rather. And there are 2 types. I won't get into the details. The names are elusive. And these are serum-based IV intravenous infusion therapies that have mixed results. Unfortunately, we're not getting a huge supply allocated to us, and that's on a biweekly or fortnightly, if I may say that, allocation system. And we're working with SVMH to get those products out to the coalition. We've also moved into more fit testing materials as N95s have become more and more crucial. We're distributing fit testing materials, and we've procured oxygen concentrators, and I'm very excited about the state taking oxygen very seriously. And they're going to be setting up, sounds like there's a proposition to set up an oxygen related call center. That's brand new news. But oxygen products and technology I believe are going to be crucial in taking the pressure off of hospitals. And then lastly, I just want to acknowledge the arrival of Deborah Hopgood, who will be helping me as the MOAC. And it's kind of grown beyond a one-person role at this point. And we're happy to have Deborah on board. So, yeah. Any other questions? Anything there covered? A few various points, but if anything there piques an interest. No questions over here. Okay.
It's good to hear that we're addressing home oxygen because I think that can keep folks out of the hospital.
Yeah, and facilitate discharges.
Yeah. Okay, well, great. We'll go ahead and move on to policy and protocol development cycle for July 1, 2021, effective date. And we have a report from Steve Brooks.
Good morning, everybody. It's unusual for me to be working remotely. I'm not sure the last MAC meeting I wasn't physically present for. So we'll hopefully make this work. If you have any questions, do feel free to stop me. And we'll see what we can do. Anyways, the policy cycle for 2021, which would have a July 1 effective date. We're in the process now of dealing with the public comments, and that part of the process, the public comment process, closed in December. The EMS agency has taken the comments received and has made a few revisions to the policies. If you look at the staff report, you will see which policies and protocols received public comment, and then the policies that we made some revisions to but didn't receive public comment. And I don't intend to discuss the policies that did not receive public comment. Those will move forward as written for a July 1 effective date. Though I will say that policy 1500 policy definitions, there may be some additional changes to that as we review the policy changes that have been made, and we may find that some of the definitions may either drop off or we may have to add one or two. Anything of consequence we will bring back for public comment, or at least discussion at the next MAC meeting, but mostly administrative changes will just move forward and be part of the release when we put them out for training at the beginning of April. All right, so we should look at the public comments that were received. And is there a way to bring the public comments up onto the screen? Public comment forms.
Give us a second, Steve. We're working it out on our end.
That's fine. There we are. Thank you very much. So one of the policies and protocols that received comment was C1 cardiac arrest, ventricular fibrillation pulsus VTAC, and I'd like to discuss that one in the context of policy 4100. So we'll move that discussion down to that topic. On C4, narrow complex tachycardia, we received comments about the wide complex pathway within the narrow complex protocol. And so we removed that because that just made too much sense. And then we've updated for the unstable sinus tach pathway, which again made sense. Can we pull up the actual protocol, which is a little further down in the packet?
And Steve, Dr. Kalinsky had raised her hand to comment. Did you have a specific comment that you'd like to make now, Dr. Kalinsky, or do you want Steve to continue?
Let's talk about this one.
When he has the policy up, I was just gonna ask, under the sinus tac that you guys added, you put for a non-cardiac with identified cause, and otherwise it looks like if that's not the case, it goes into a defibrillation. And I was just wondering, since sinus tachycardia is responsible to all kinds of things, including cardiac causes, why we would move to potential defibrillation with that exclusion rather than just sinus tachycardia identified.
Good question. We actually did make an additional change, which would be to create two pathways, one for sinus tach and one for SVT, because they do have different needs.
Right, I saw that, but if with the exclusion in your language, what it says right now is sinus tachycardia with non-cardiac identifiable cause, and if that answer is no, then it goes to the cardio version. But it can be sinus tach from a cardiac cause too, you know, like an MI. So no sinus tach should be cardioverted. So I don't see why you just don't remove that language.
Steve, are we able to pull up the algorithm there?
Give me a second here. Let me see if I can get this, and then we'll work on sharing my screen if we can. Give me a moment while I open this up. Maybe. Unfortunately, my computer's working relatively slowly, trying to do a process I didn't ask it to do. And when it involves PDFs, my computer from home works very slowly. But I will have an update here for you, hopefully in just a moment. Maybe. Thank you. I love technology. And while we're on the subject, so we can continue to move while I wait for my technology to catch up with me, we had one other comment on narrow complex tachycardia C4, which talked about post cardioversion sedation, and we didn't make a change. We felt that sedation should occur before the person receives the jolt of electricity. And if it's okay with you, because this is actually moving really, really slow here. If it's okay, can we move on to C5 and then we'll come back to C4? That'd be okay by the committee?
Yeah, that's fine.
Okay. So C5, symptomatic bradycardia, comment to have pacing, first line of treatment for third degree heart block and Mobitz 2, which we've made that revision. We're going to work to have more consistent language. We do see that how we deal with oxygen, at least the statement seems to be different between a couple of the policies and protocols. So we'll be standardizing that as we move through them. We did make the correction within the flow chart on the far right side regarding atropine, and the way the flow chart works it's not a consideration. There we go. Give me a moment. I should be able to pull these up if I can share my screen. So give me a moment here. All right. If I hit share screen, will I be able to share my screen, April?
Yes.
All right.
Hey, Steve, you have a Huve and Estella over here.
Oh, Huve's there. Okay, thank you.
But yeah, share screen and then share should do your entire screen by default.
There it is. All right. Does that share my screen?
Yes.
All right. So you
Can you
see here-
expand the protocol just so we can see it better?
give me a moment here. All right. Is that better?
If you can make it as big as possible.
As far as horizontally, that's as
Yeah.
and vertically, that's as big as I can do. Let me move it up a little bit.
Are you able to like zoom a little bit? Because it's just a little hard to read the text there, Steve.
You have a zoom slider at the bottom.
At the right lower quadrant.
There we go. Okay.
Steve, this new policy fixed the issue on the one that you had sent out with the prior packet.
I believe, oops, sorry. I believe so. Give me a moment to go back.
No,
to-
it has. The language is different.
Yes.
The only other question I would ask is I noticed that you mentioned AFib flutter on the stable side, but only AFib on the unstable side. Does that mean you're authorizing cardioversion of flutter, or do you want that called for as well?
It looks like it's actually on both sides.
No, it says atrial fib or flutter on your stable side, but it only says AFib with RVR on the unstable
see.
side.
I see what you're saying.
So does that mean they're authorizing cardioversion of flutter, or do you want both of them called for?
Yeah, I think the intention was to include flutter with fib on the unstable side.
Is there a recommended revision?
I think the recommendation, if I'm understanding it correctly, Dr. Kalinsky, is you like the verbiage on the unstable side is patient in atrial fibrillation / flutter with rapid ventricular response.
If you would like base physician consult prior to cardioverting unstable AFib or flutter, then I think you need to include both of them.
Yeah, I think that's fine.
Okay, thank you. So as you can see, we've updated the pathway so that we have an SVT pathway, which if it is, we move down to cardioversion. If it's a sinus attack, we're looking at underlying causes. It should simplify things.
Any other public comment on this particular algorithm, Steve?
I don't, this is C4. No, that was the main comments. And please forgive me, some of these directional pathways are not quite straight. I'll be cleaning those up as we finalize the document. Okay, let me come back to. All right, am I still screen sharing? Because you guys
Yes.
can see the public comments. So that's C4, C5. Symptomatic bradycardia. Let me pull that up here. Pardon me for a moment, I'm gonna move this so I can read it. All right, so as you can see, we have transcutaneous pacing has been moved up to the priority treatment for Mobitz 2 and third degree block. And again, the language for oxygen is going to be made consistent. And then over here with atropine, for the patient who does not improve, we would like to have them move over to the pacing side of things. If there seems to be improvement, then we will continue giving atropine. And then we added the considerations for other causes, I believe. It was overdose. Let me see where that showed up. Oh, down here at the bottom. We added language to help folks in the field remember that we do have potential treatments for specific causes of symptomatic bradycardia and to follow the protocol E5 for that. And then there was a comment related to the fluid bolus of 500 to 1,000, and we left that alone. And those are the comments on C5, symptomatic bradycardia. Are there any other comments, questions? Hearing none. We have C6, wide complex tachycardia with pulses. And we have torsades on the stable side, and we will update. We've updated the flow chart. We'll show you that. We agree that there should be an additional dose of lidocaine, and as far as post-cardioversion sedation, we believe that sedation should be before the cardioversion. And the wide complex. Let's see. We created a note, as we did with the bradycardia one, for paying attention to other protocols. And the question is that showed mag sulfate, but that's not in the authorized stock policy, so that will be updated as far as the authorized stock policy. Give me a second to pull this one up. So we'll be updating the authorized stock policy as necessary to address some of these policy and protocol changes. So here's the wide complex tachycardia with pulses. And we have torsades over here. As you'll see, we've cleaned up some of the plumbing. Before it looked like bad diagram. Now we've got a little more clean lines and directions.
Steve, Dr. Kalinsky had raised her hand with a question.
Yes, go ahead, please.
Oh, I just had a question on your stable or unstable. So as you go to the no for the stable and the immediate synchronized cardioversion, I'm wondering why there's not an allowance for co-administration of antiarrhythmics with the actual cardioversions, why you have to be converted out. Because a lot of these will deteriorate if they don't successfully cardiovert, and an antiarrhythmic may be beneficial and enhancing cardioversion.
I think that's a fair point, Dr. Kalinsky. I think the like general premise was not to delay cardioversion with pharmacology if the patient is clinically unstable and meets those parameters over there in the first right blue box.
Completely agree, but the way your chart goes, it looks like you have to cardiovert out, which, you know, may delay co-administration and impede your ability to cardiovert.
So maybe a note that concurrent administration of antidysrhythmics may be helpful. I guess I'm just imagining the paramedics in the back of the unit trying to prioritize what to do next, and you know, getting the patient cardioverted versus grabbing the medication and administering that. And so I have no problem with co-administration. I just don't want folks to have to delay electricity in the unstable patient.
Completely agree. I just think an allowance for co-administration may be beneficial in that patient requiring repeated cardioversion.
Thank you. Well, Steve and I can take a look at incorporating that in.
As far as this discussion goes, over here on the left, would we want to? We've got cardioversion first. If it's persistent, would we want to consider it here right under the yes, or down below the second cardioversion? Just so I can.
I would just put in your box after the yes, where it says repeat cardioversion, right below that, put consider co-administration of medications and draw a line to your lidocaine.
Can you move down a little bit, Steve?
Yes.
So if you move your cursor up just a little where it says repeat cardioversion, increased joules per manufacturer, if below that you put consider co-administration of antiarrhythmics and then draw a line from your box with the repeat cardioversion to your box with the lidocaine, that will work.
I think that's good. I think that's reasonable.
So just below the repeat, I can do that. Okay. And as you can see, as we get down to the bottom, also the notes. Any other questions or comments? All right, thank you very much. All right, so the next one that received comments is protocol N3 seizures. And there's a question on the repeat dose of Versed and how it was stated might not be as clear as we intended. So we've revised the language, which we will show here. There's a question about adding blood glucose check in the ALS section, but it's a BLS skill now, so it's in the BLS section. So we opted to leave it there. It keeps the policy a little more clean. And talking about the Untitled CO2 being monitored throughout, we elected not to add that language into the seizure protocol. Let me pull this up and you can see. All right, the seizure protocol that was distributed Again, blood glucose here. And then what we've done is we've revised the second dose language to be the same as the first dose. And if you bear with me for a moment, let me see if I can show a clean copy. So this is what it will look like when we release it. And here's how the second dose language shows up. It's essentially the same language as the first.
Steve, Dr. Kalinsky had raised her hand with a question.
Yes, please.
Oh, just since your notes have the blood glucose under the ALS stuff, I'm assuming that this can be done as a BLS protocol concomitant with benzo administration and will be done early, right?
We would-
That was why I asked that, is because it's listed in the notes kind of at the bottom after all this care, and it's really something that should be done concurrently or early in the course, rather than having it in a note section after all these ALS repeat benzo procedures. Because the last thing you want is to miss hypoglycemia and be repeating your benzo doses, establishing lines, and you really should be treating with dextrose.
Yeah, I think the intention there is that it can be done concurrently, which is why we have it up at the top of the algorithm there under a BLS skill.
Then maybe remove that note from the notes and put do not delay benzodiazepine administration to check glucose, do concurrently or something. Because the way it read to me was you need to go through the ALS and then check this after. Which would be, multiple doses of benzos and potentially 5+ minutes of seizing from hypoglycemia, maybe.
So if I put in here instead of right after, put it after initial benzodiazepine administration?
I would just put do not delay benzodiazepines for a blood glucose check as early as possible as a BLS part of your protocol. But don't delay benzos, but also don't delay the sugar check waiting for all this ALS procedures, because you're going to miss a hypoglycemia that should be treated differently.
Maybe we could have that note as the verbiage you were suggesting is, do not delay benzodiazepine administration for blood glucose checks, but check blood glucose as early as possible. That's kind of generally what you're recommending.
Yeah, because just the way it read, I saw it up in the BLS part, but under ALS care, it looks like you go through multiple doses over periods of, 5+ minutes waiting to check a sugar.
Right. So what I'm recommending is, this. So here you're not delaying your benzodiazepine, but after you do that, you do a blood glucose check, because you're not going to, slam benzos right after each other. There will be a, time to do the blood glucose check.
I would just say, rather than make it routine as sort of an aside, this is an immediate check in a seizure, right? So maybe change that to, this should be a priority.
But I think the intent here, Dr. Kalinsky, was not to delay benzo administration while you're checking blood glucose. So I think.
Right. So if you change routine to immediately checked after benzodiazepine administration, it accomplishes both goals. This is something that should happen simultaneous, since you hopefully have a BLS and ALS provider if possible. But if it can't, it seems that we would want it earlier.
Earlier than
waiting through your full ALS protocol.
I think that's where Steve's verbiage comes in there down at the bottom, Steve, doing a blood glucose check after the initial benzo administration.
Because I would also put here, something like, I mean, I don't like the language, but basically, as I envision the call going, you have BLS on scene, and if there's any sense of hypoglycemia in the patient, they should be checking the blood glucose awaiting arrival of ALS. If ALS shows up, we do train, BLS before ALS. We would hope to do it, but if the patient doesn't have a history of hypoglycemia, actively seizing, we're really going to try to stop the seizure. I believe the medic would go right to midazolam and then check the blood glucose. So either way, I see it happening early, but not getting in the way of the midazolam. At least that's how I see this written here.
How does that sound, Dr. Kalinsky?
I think it's better now that we put initial. That helps quite a bit. And as long as the training's right, I'm sure it'll be fine. I just, would hate to see them go through the whole ALS thing for 10 minutes and then check the sugar and it'd be 20.
Right.
Right. And again, that is the intent. And we can make sure that as part of our training materials that go out with this update, that we can mention that so that it's reinforced.
And then I think Will had a question. Go ahead,
But
Will.
down at the bottom, if
Sorry, Will, your mic's not picking up. If you want to, Will, if you want to text me your question, then I can read it,
Or on question and answer.
or on the Q&A. Anything from William?
I see Eric also has the same issues. Are you able to allow to talk? Yeah. 'Cause I couldn't. Eric, go ahead.
What's that?
Eric Owen also had a question.
Okay, did we get Will's question yet?
Okay, yes. Oh no, not from.
We have Eric's typed out.
Okay. Go ahead with Eric.
Steve, apologize if it's skipping ahead, but can you
Uh-huh.
discuss the shift in the assistal PEA protocol from 20 minutes of CPR and 2 rounds to 30 minutes and 3 rounds? I thought
We
we
will
agreed that
talk about-
hospitals do not want dead people.
Sorry,
we will-
so
we will
yeah,
talk
so
about-
we'll come to that in a second. I just want to finish up with this protocol before we move on to the next.
Yes, we'll be discussing that in policy 4100, I believe.
You guys, so from a panelist perspective, I can't ask a question, so there may be difficulties with that.
You can't ask a question?
Yeah, like if Will's mic's not working, I can't type a question in the box the way it's set up.
All right. Thank you for letting us know. We'll see what we can do to make sure that that works in the future. But do feel free to jump in if you have any comments. All right. Anything else on the seizure protocol? All right. Thank you very much.
Hold on 1 second, Steve.
Oh, yes.
You have something?
Allowed to talk.
Hey, Steve.
Yes, sir.
Hi, Dave Jednick here. I just got a question looking at the seizure protocol with regards to the maximum dosage for the Versed. For IMIN, we're using the 10, 5 or 10 milligrams max, but then we go into IV and it's 0.1 milligram per kilo up to a max dose of 4 milligrams. That's a very small, I mean, we could have what, a 100-pound person get 4 milligrams and a 200-pound person is going to get 4 milligrams, or a 250-pound person. So is it necessary to have a minimum or maximum dosage in such a small amount, or unless I'm missing some? Also, can we move that into increments of 5 instead of the 4 and the 10?
I'm going to go back to my recollection is that due to the, mechanism of it moving through the, metabolizing process, 10 seemed more necessary IM than the 4 IV. And if it's me, I'm okay with 5, but that's a medical director response.
And the reason I suggest that, we in Carmel, we carry 5 milligram vials, so it's not the 2. It used to be 2s, and sometimes I get 4s. It just keeps it more seamless that way. We can, max dose 5. We know, hey, we got somebody actively seizing, they're over 100 kilos. We can give them the whole dose or whatever. So.
Dave, I'm okay with that change. And this is also, keep in mind, this is the max dose for the initial bolus,
Yep.
and you can also repeat boluses. So
Okay.
we're not saying that you can't give any more than that. It's just that this was the max dose for the initial bolus.
I think that's great. Thanks for the 5. That just keeps it easier for our supply. So.
Do we have a question yet?
Eric will one.
Eric has a question. Go ahead, Eric.
Can you unmute yourself, Eric?
What's that?
Eric, to unmute.
Eric, you're on mute. If you have a question, if you can unmute.
No question from Eric.
Okay. Any other questions on this protocol before we move on? Okay.
Thank you
Okay,
very
Steve.
much. All right, the next one is N4, suspected hypoglycemia, and a question on glucagon. Is 5 minutes enough, time for glucagon to work, and maybe 10 to 15 minutes? So we revised the moving to IO after 10 to 15 minutes. And we agree that it may be needed for clarity to update the dosing of dextrose to after IO access. And we're working on making it a flow chart. So let me pull up N4. So here's N4. And you can see that we've added 10 to 15 minutes and then added, the dextrose intraosseous after the, if there's no improvement with glucagon.
Can I ask just one question about this?
Yes.
Is there a reason we don't just give the glucagon and then work on establishing access to be able to give dextrose? Because most of these patients are going to need the dextrose at some point anyhow, while we're waiting for the glucagon to work. I mean, the glucagon is quick, easy, put it in the muscle, and then work on establishing an IO or an IV to give some dextrose.
Yeah, I think the rationale behind this is, generally glucagon is used if you're having difficulty establishing peripheral IV access. And so in that situation, you're administering the glucagon and hopefully the patient has a response at the same time you're packaging, you're moving to the hospital. And maybe not all of these patients need IO access. Oftentimes, once they get to the hospital, the ED nursing staff is able to establish a peripheral line and avoid the IO. So we didn't necessarily feel that it was important to have medics go right to IO access after administration of glucagon, since glucagon may do the trick, and by that time, in many cases, you're at the hospital. You have more staff, better lighting to establish a peripheral line.
Sure, that makes sense. If it's a short transport time, if they're coming from South County or something like that, they'll probably have time to find access otherwise if the patient doesn't wake up.
Right.
Okay.
I mean, do we really want to leave somebody hypoglycemic and unresponsive though for 15 minutes and then decide to do an IO? Is that the recommended time frame for this?
I think part of this is a judgment call. How hypoglycemic are they? Initially our protocol had stated 5 minutes, and so that is a pretty short amount of time. And then the recommendation was just to increase it to 10 minutes, since the response time can be a little slower. Your point is well taken. I just don't know if we want to write a protocol where every patient who can't get a peripheral line gets a dose of glucagon and then an immediate IO.
Well, I mean, maybe then we should be more specific in terms of the overall instability of altered level of consciousness, because, awake and still talking is a lot, but confused is a lot different than some of these other cases. And maybe just kind of how severe the reaction is would prompt an earlier IO access. I don't know.
Right. So that might be a consideration, whether we want to put in a GCS or something like that as a trigger for more immediate IO access.
It just seems leaving somebody profoundly hypoglycemic, like if the sugar's 20 and they're losing their gag and they're fully unresponsive, waiting 10 to 15 minutes for glucagon in this hypoperfused hypoglycemic patient just seems like a overall bad medical care.
Yeah, I agree with that specific case. So, perhaps we can put in some verbiage, to delineate the level of consciousness and how quickly we want access obtained.
I think that makes sense, and we can certainly do that, Dr. Burley. Any other questions, comments? So at this point, and this has not been part of the discussion, but in looking at this protocol, one of the things that is a corollary that perhaps should be adjusted is the glucagon dose. We never repeat the glucagon for a single patient, and so the most that under this protocol any patient will receive is 1 milligram of glucagon, but our authorized stock policy requires a minimum stock of 2. In the face of glucagon right now being in shortage, though I understand there's a generic just been approved, and due to the great cost of glucagon being one of the more expensive things to stock, what do I guess that my thought is we should consider decreasing the minimum stock of glucagon to just 1 milligram to help manage supply for something that's honestly really not used all that much.
Is it approved in any of your tox policies at higher dosing?
No, this is all the only place glucagon is used, I think, unless and give me a moment here.
Overdose.
Unless it's in the overdose policy.
Right. If it's in your toxicology policies, I have a feeling your doses are going to be higher.
Right, so let's, let me check and pull that up.
Because for beta blocker and calcium channel blocker overdoses, significantly higher doses of glucagon are required.
All right, here's our overdose and poisoning policy.
It's 3 milligrams.
Right. The standard starting dose is going to be 3. So that's going to be an indication to have higher doses if you're going to leave that as a treatment option for you guys.
There we go. Yep, that makes sense. For beta blocker overdose, I believe we're going to need to keep it. Okay, thank you. All right, thank you. Any other comments or questions on this, on suspected hypoglycemia? Give me a moment. Yep, thanks, Ben. All right, hearing none, let's move on. Lost my cursor, here we go. All right, so what we have next is pediatric seizure. And the comment was the single max dose needs to be more clearly stated. We believe it's fairly clearly stated. Let me pull it up.
Hey, Steve, I think this policy also has the same note at the bottom. If you can just make it consistent between the adult and ped seizures, that would be great on the sugar.
Oh, yeah, that would make sense. Give me a second to make that note. Thank you. All right. Pediatric seizures. And we'll change that down here to make it consistent with the adult one. Anyways, we believe the dosing is consistent. And Dr. Burley, should we also change the maximum 4 milligram to 5 milligram?
Yeah, for the larger, yeah.
Okay. Thank you. Any other comments or questions? All right, hearing none, thank you very much. All right, policy 2080. And this is a new program related to paramedic preceptors. And the intent, of course, is to try to bring the preceptor qualifications in line with the state guidelines, and also to provide some county provided minimum standards for being a paramedic preceptor. Comments related to what to do about current preceptors. We don't want to, with this policy, add or decrease anybody's ability to do it. As long as they meet the minimum standards, we fully expect preceptors to continue to be preceptors. We're not looking to exclude anybody. This is truly not a a policy of exclusion, simply a policy to establish baseline standards as well as consistency across all organizations, as well as to give the EMS agency a more direct contact with the preceptors so that the information that they're providing to our newest of paramedics is consistent and as direct from the medical director source as we possibly can do. There's a concern about the peer review panel. That requirement has been removed. And the number of meetings, we've proposed 2 preceptor meetings a year. We want the preceptors to attend both, but we also understand work schedules and other things that come up. And so the minimum standard is 1 meeting a year. We don't believe that that is excessive. There's a concern about having more meetings for the preceptors to choose from. But to be honest, that adds a great deal of workload to EMS agency staff. So we've left it at two meetings that we want the preceptors to attend, with the requirement to attend just 1. And I'll pull this.
Steve, this is Scott. I got a question on that one.
Yeah, Scott, I'll pull up the policy here. So
Go ahead, Scott.
Yeah, you know, we've had such a challenge with the pandemic. We don't know what the process is going to be in the future. Can this be set up as a remote learning opportunity? Having a specific day for only 2 days can be a huge challenge. And I agree, the communications needs to be flowing both ways in a consistent manner, without a doubt. But just having the 2 workshop days does limit the ability to get people in there, and having a provision where there's a space to log on to get the information, have an interactive site, much like the other continuing education sites, and the avenue to contact personnel needed for answers would be a really important component to include in this.
And honestly, I don't disagree with you at all. I think there's benefit for, even like we're doing, you know, Zoom meeting, remote access. That's, you know, we'll use all the technology and all the abilities that we can to make this as accessible a program as possible. And, you know, again, in pandemic situations, we will stretch as much as we can, do whatever we can to meet the program goals, which is information flow. And, you know, as far as the meetings go, we'll in my mind, we'll do whatever it takes. So that's our commitment. We want this to be successful and not be a barrier. Because if, as you described, if people are unable to attend meetings, we don't want them to give up. We want preceptors. We want them to be well trained. We want them to meet minimum standards, and we want them to have the best information. So we want participation. So we'll do everything we can to get that. That's our commitment. Plus, we'll put out the calendar of the meetings, you know, as far in advance as possible. You know, so like for 2021, we'll likely have 1 meeting with, you know, in the last half of the year. We'll put that as early as we possibly can, so that everybody, you know, that's a preceptor can meet that date. Any further comments or questions, concerns?
Just a reminder, anyone attending as a panelist for these morning's meetings, you can go ahead and unmute yourself at any time. If you have to ask a question, of course, just observing etiquette, talking over one another. It's just like
All right. I'm looking at the clock as I'm also doing this. Do need to move on. So that's paramedic preceptor. The next one is policy. Whoops, excuse me. Policy 3080. Comments related to communications. We agree that the language in 4040 should be the same as 3080, and we agree we shouldn't in the policy designate or state the names of the facilities, but the nearest stroke and STEMI. So we've updated that. What I did send out missed under stroke, so that'll be updated. We've fixed also the typo. Does anybody want to see this policy? Otherwise, we are going to have a lot of discussion on 4100, I believe. I would very much like to move on to that.
Yeah, well, Steve Scott, again, one quick question on this policy. We've had some outreach from the trauma center to create some communication upgrades. I'm trying to avoid confusion with our personnel and trying to streamline the dissemination of these processes. So I guess my question is, this is in coordination with the trauma center and their desires to try to update the communications at the patient handoff. Good.
Thank
In
you,
the question.
Scott, are you talking about just the handoff project that Scott Whalen is doing to basically give you a minute pause that we should be doing anyhow in the SBIRT?
Yeah, correct. And I guess getting different messages from different providers creates a whole level of confusion for us as providers. And we'd like to have one streamlined dissemination coming through the authority, because that's the medical control we work under.
Right. I think probably TQuick is probably the right place to have that discussion. The intention is basically to just do a 30 to 60 second pause right when activation trauma patient comes in, so that you as the EMS providers are able to actually give us the handoff, and we'll give you that respect for that 30 to 60 seconds to do so. So I think we can talk about it more at the TQuick meeting when that happens. But the biggest change is really just to have that formal pause to get the formal handoff before we move the patient over, unless they're unstable and need life-saving interventions.
Oh, thanks for the clarification. Yeah, I think
it's something we should have been doing all along.
Yeah, and maybe not this forum, but offline, we probably should have a more clarity to the discussion to make sure we got our information to our folks.
Yeah, just reach out to me and I can send that out in a more easy to understand way.
Thank you very much. Appreciate it.
No problem.
Yes, we will be working with coordinating the desires of Natividad. I like the pause idea. The format we will need to coordinate. You're right, Scott. We don't want conflicting processes. All right, not hearing anybody wanting to see the policy. Policy 4100 has a lot of questions. One is we need trauma center input. I've not heard back from Natividad related to what the trauma docs would be thinking on this. So hopefully we'll have additional to follow. And then as far as the base contact goes, when that should occur to get physician involvement in the determination of death and what that all makes. So let me pull this up and I'll be with you in just a moment. All right. We are getting short on time and I apologize for that. These public comment ones always seem to go fairly long. So, comments and questions related to our response. Give me a second here while I pull this back up. Anyways, what we're really looking for in this is to have physician involvement to ensure that an individual who's not in the heat of the moment, working on the resuscitation, be involved to help make the decision-making process easier for the field personnel. That's a lot of what our intent is. And with that.
So, I mean, since they're mostly my comments, I suppose I can kind of, I guess, briefly discuss the concerns, although I think that they've been gone over fairly well with Dr. Burley. And that is, there are many EMS agencies and many studies that have looked at and determined kind of criteria that you can use to almost universally determine who's going to have a bad outcome. You know, even if they survive to admission, their neurologically intact survival is very, very low when those criteria are met. I can tell you that from a base physician perspective, our comfort level at doing things over the radio like this is going to be mixed and not standardized. And there's probably no way around that. Many physicians are going to be much more comfortable taking this call and saying, yeah, pronounce, don't transport. And some folks are just going to say, you know what, I'm not going to decide this on the radio. Just bring them in. And so you will likely have more transports of non-salvageable patients. And no, we really don't want to have dead people at the hospital, but this is just a situation that, as uncomfortable it is for Dr. Burley, it's the same for every single individual base physician out there. And there are a lot of large systems that have standardized this to a best practice. And I was hopeful that we could use some of those ideas. You know, most predominantly, the patient had no shockable rhythm at any point, that their end-tidal CO2 is incredibly low, that they've gone through appropriate ALS, they've had the airway, they've had the drugs, and continue down the pathway that we had previously. I can tell you also that currently in the COVID era, it is going to become extremely difficult to get a base physician to a phone in many cases. There are times where our facilities are still single physician coverage, and there are times where we're in PAPR and we're not going to be able to get out and talk with you guys. And so the delays in getting a physician to the base phone is going to be potentially significant. And although these policies probably won't be in place till July, you know, I don't know that we're going to be completely out of this. And I don't know that we're going to be, you know, out of hot zones and able to come to the radio. So these were my concerns. I think you're going to have more transports. I think you need to prepare for that within the system. That's with my physicians just briefly discussing this. I haven't told them it's going to implement, because I was hoping that we could make some determinations with what's happened in other systems and incorporate those in ours. But it sounds like that's not something you want to move forward with. So those were the concerns.
So Steve, thanks, Dr. Kalinsky. And, you know, we've had a fairly extensive discussion about this, and I had, you know, let you know about what my concerns were, and Steve and I have gone through this policy and taken some of your comments and tried to implement them here so that we have a more of a mix of a hybrid of you know, both of our concerns. And Steve, do you want to comment on what changes we've made to this policy since those discussions?
Oh, goodness. Sorry, my mind was going to a few other things, trying to do too many things at once. We really didn't make a lot of changes. I mean, you know, Dr. Burley and I, you know, have had a lot of discussion on this, and
so the comments that I had sent you via email there, Steve, to incorporate into this policy.
Right.
Have you had time to incorporate those?
No, I haven't, mostly because those ended up in the in our comments, you know, response to that as to why we're doing all of these things.
So I think what we've done is establish parameters by which a patient can be declared dead and not transported without base hospital physician consultation. And so you have in this policy, you know, sort of hard rules as to when paramedics make that determination and don't need to get a physician involved. And then to sort of honor some of the concerns that I had, we're going to add some verbiage to the protocol so that paramedics have the ability to contact base hospital physicians in cases that are equivocal, in cases that are gray, and there's some uncertainty as to whether to call the patient in the field. Some of the things that I had brought up were young patients who arrest suddenly. You know, I'm thinking of athletes who arrest, you know, during a football practice. Patients who are hypothermic, and patients who have had, early CPR, immediate CPR. So there's a lot of caveats to whether to pronounce someone right away or to give them the benefit of the doubt. And I think every physician is different in how long we'll work patients and under what circumstances. But it's an important decision. It's probably one of the more important things that the EMS providers and the physician will do during the course of their shift, is deciding whether a patient is potentially viable and whether to work them. And I just felt that having a physician input, particularly on these equivocal cases, is to the benefit of our patient population. And if the physician feels that no, this patient does not need to be worked, they can be pronounced in the field, then the patient doesn't have to be transported. So I don't know that necessarily the number of transports would go up. In some cases, potentially the number of transports might go down if EMS staff feels more comfortable contacting a physician, running it by them, and getting agreement that the patient doesn't need to be transported. Then some of those equivocal cases that might have otherwise been transported in can stay at the scene. So I think that was sort of our intent. And I'm sorry we don't have the updated version to show you guys, but we can continue to work on this over the course of the next few weeks and continue to dialogue with you, Dr. Kalinsky, and bring this back to the group.
Yeah.
Dr. Burley?
If you could send it out for review, I think that would be great, because I do think there's, some reasonably good data and best practices that if we incorporate those, it'll capture the groups that you're worried about and not necessarily. I know my groups of physicians. I don't know about Salinas and Natividad as well, but for us, we're going to have significant variability in terms of the likelihood that they're going to allow field pronouncement if it's not within a policy criteria. And they're going to probably want to do that in person in a lot of cases. The other concern I do have, you guys, is, and I think that maybe we can decide this here with Cole, I think there's a lot of data that shows that penetrating kind of early PEA can sometimes be reversed with initial advanced trauma interventions like needling both sides of the chest. And I don't think that's a bad choice to not pronounce a penetrating PEA with a low rate. So I don't know if Cole, if you have enough say for that to leave that in, but I think, if you've got blunt, it's a lot different than penetrating.
I think it just depends on the downtime. I mean, if you're more than 10, definitely more than 15, if you're more than 10 minutes away from you being able to have definitive care, it's probably not useful. But I think also there's very little harm in needling both sides of the chest in a patient who has a traumatic arrest. I mean, you can't make them more dead. And
right.
So I think it probably is a reasonable thing to do, to needle both sides of the chest, because if you get a pulse back, then all of a sudden that's potentially a salvageable patient. And it's minimal risk to the EMS provider and essentially no risk to the patient.
Right. I mean, that's what I was thinking, is like, you got a penetrating PEA that, if you
right.
can back.
I think that should probably stay in.
Yeah, and we had reached out to Dr. Distante as well to get comment on that. And we haven't heard back yet, but Cole, maybe if you can just put a bug in his ear to, chime in on what his thoughts are on this policy. But I'm in agreement that patients who sustain penetrating trauma and are in a PEA arrest may be salvageable, particularly if they have a reversible cause like tension pneumothorax. And so I have no problem removing that from, the bradycardic PEA from the trauma algorithm for penetrating trauma. But maybe we can just get, the input from Dr. Distante as well.
So
Yeah, I can see if I can get him.
Thank you. So here's what I'm going to propose, is that we bring this back for public comment, a short public comment period, and then have this further discussion at our March MAC meeting.
Yeah, can I just have one comment or a couple questions here on the determination? I mean, we're talking about not more than one patient per day, are we, that this would ever affect? I mean, a pretty rare occurrence. And I understand that, there isn't always a physician available at the base hospital immediately. But I mean, I think it's we should be willing to speak with the EMS providers if they have any question and help to iron out and come up with a solution together. I mean, what about if a physician at the initial base hospital is encumbered, that the EMS provider can call one of the other base hospitals if it's a situation in question? Because I would think that one of the providers at one of the base hospitals would be available to get on the phone and to have that conversation with the EMS provider if they're in need.
Yeah, and you know, we did run through the numbers to take a look at how many cases this would affect, and your comments are appropriate that there's a very small number of cases that run through the system on a daily basis. It's less than one case per day. And then when you look at those cases being divided up among the 4 hospitals, it's you know, somewhere around
Pretty rare.
Yeah, it's like one patient every 4 to 5 days. And so we didn't feel that this was necessarily an extreme burden on the ED physician, and we felt that it was an important part of the job of emergency medicine.
Yeah, so I think it's something we should be able to figure out how to accommodate. And, you know, again, if it's single coverage and if the provider is encumbered, then I think we should just have a backup plan where it goes on to different base hospitals. I mean, it doesn't matter if we're sitting in South County, if we're sitting in the north part of the county, we should be able to, on the phone, reasonably come up with a solution with the EMS provider with the information they're able to give us.
So since we're going to bring this back, let's move on from this policy, Steve, because we are running really short on time, and see if we can finish this up.
Yes, I agree with that. And Eric, I got your idea. Thank you very much. We'll be discussing that and bringing that probably involved in the revision for public comment that will be released soon. All right, policy 6020, we also had comments related to the unusual occurrence reporting. It didn't make mention of the use of the web portal for UO reporting, and the policy's been updated to use that as the reporting method for unusual reports. Any comments on that, and does anybody want to see that one? Hearing none. Okay, that's it on these. Now, the staff recommendation is that we request an endorsement of the policies and protocols as updated, pending, of course, all the changes that were discussed here, and bringing back C1 and 4100 for additional discussion after additional public comment period. But that's up to the group. That's just staff recommendation.
So can we get a motion on the floor for acceptance of the policy update pending those caveats?
This is Tina Nieto. I move that we accept the motion, except with the caveats that he spoke about.
Thank you. And we have a second?
Scott Houchin here. I'll second that.
And then we'll do a roll call. What's that? Any further discussion on the motion on the floor? Okay, so we'll do a quick roll call.
All click aye.
Jeff Warner, aye.
Tina Nieto, aye.
Scott Houchin, aye.
Kelsey Caldera, aye.
Michelle Kalinsky, aye.
Christy Sobolewski, aye.
Dave Craddock, aye.
Is that everyone? Okay, thank you. And so the motion carries, which brings us on to new business. Steve, you have an update on new business. January 2021 policy rollout.
Yes, thank you very much. The January 21 policies have been released. They're now in effect. We're going to be sending a survey form to our providers to check on how the rollout is going. We'd like to, check to make sure that the equipment's been purchased, verification that the training's been performed, and just, again, try to verify that, our intent is being followed in the system. After some delay, our policies are updated on the website, so you can find the new policies and protocols there. I've had a little bit of trouble coordinating with the app developer, so they're not on the app yet, and hopefully we'll have information to distribute about that fairly soon. I also want to ask, are there any questions or comments regarding the rollout that we made effective January 1?
Hello, Steve. This is Scott again. I got a quick question for you too. We seem to average a policy a month, and we do them twice a year. We had made great efforts to try to streamline this a little bit. I don't think there's a crystal ball that tells us what the future holds. However, what is the plans moving forward? Are we looking at a pace continue with this? It's a bit of a challenge having the twice a year rollouts.
Good question. And I'll go back to, it is absolutely our intent to do as much as we can on a once a year rollout. Unfortunately, as we all know, things come up and change, and to best, weigh the benefit of, patient care versus, the ease of the transition to ensure that it's effective and smooth. We'll do everything we can to have once a year, but sometimes, unfortunately, we're just going to have to do it and do a second rollout. We'll try to not have anything, on a monthly basis that affects field care. Especially, we may need to do some administrative things, because you'll hear that some new policies are coming here very soon, and those will just unfortunately have to be off cycle. But the intent is once a year, if at all possible.
Thank you.
Okay, if there are no more comments under new business, that'll move us on to EMS System Quality Improvement Program reports for CQI TAG, STEMI, Stroke, and TQIC. And just a general comment that we don't have specific reports for these groups today, because we have postponed some meetings in light of the pandemic and other issues. But given the new year and some new staffing in the agency, we'd like to change the tone of some of these meetings. Historically, I think the meetings have been, especially STEMI and Stroke, have been mostly data reporting and less robust discussion about best practices, how we can improve clinical delivery of care. And so we just like to take a slightly different tone in meetings to come, in which the data is delivered to committee members early and ahead of the meeting. We can discuss data briefly, but we like folks to have an opportunity to look over and digest the data before the meeting, so that we can spend our time focusing on best practice, recommended changes, and delivery, and then also doing some brief case review on cases that went particularly well, or cases in which challenges have come up and how to avoid those in the future. So that's kind of the general tone we'd like to take for meetings coming up in 2021. And unless there are any specific comments about that or questions, we can move on to the next item on the agenda. Okay, hearing no specific comments, we'll move on to EMS Agency Updates with Teresa under reports.
In the interest of time, I just want to highlight two things from the staff report. In the staff report, we reported that we submitted a local scope of practice to authorize EMTs to administer the influenza and COVID-19 vaccine to EMS personnel and the general public. Our application got approved yesterday. We're very excited about that. The information about that how to apply is going to be going out in the next couple of days. Major kudos to Steve. He worked really, really hard on this application. We also found out that there's there may be some monies available for reimbursement for some of the costs related to the vaccination of members of the public. The other thing I want to highlight is just welcoming the two new members of our team, Kimberly Hernandez and Deborah Hapgood, have joined the EMS team as EMS analysts. They both have a very strong skill set and experience in EMS. They both have already started making very positive contributions to the team. You will start to see that in future meetings in the way that we are looking at data and presenting data, just as Dr. Burley mentioned, that we are doing a reset on some of our committees and having a more strategic planning, trying to do some strategic planning with our committees and just even internally within the agency. So welcome to both. I know some of you have already been introduced to them via email, and you'll hear more of them in the future. That's the end of my report.
Okay, thank you, Teresa. We do have an item on the agenda here for emergency communications drill report from Jeff DeAndrea. Jeff had to step out.
I would ask that we table this item to the next meeting. The one thing about the radio testing that I would like to share is that in the month of December, the testing did not get done the entire month because AMR dispatch moved from the communications building on Natividad to the backup center here at Schilling. And so there was a period of time when they were not able to do that testing, but we will update the data by the next meeting. We can report that the dispatch center operating out of this building, the backup center, seems to be going well. There were some hiccups, but I think they handled those very well with the help of our county IT department.
Excellent. Thank you, Teresa. And then the next item on the agenda is APOT times, and Kimberly Hernandez has a report for us for that.
Can you stop sharing your screen? That way I can share mine.
Oh, yes, Steve. Yeah.
Thank you.
Go ahead, Kimberly.
Okay, good morning. So we've collected some APOT data comparisons from 2019 to 2020. And once Estella gets it up on the screen. Okay, you can go to the next screen. Okay, so there's been increases in APOT times since July in the overall average and in the 90th percentile overall. So if you see the numbers when we're starting in July, it started to increase again in the overall average and in the 90th percentile overall. So the December has had the largest increase thus far in the overall average and in the 90th percentile for the hospitals within the county. And then you can switch to the next slide. Since July, there's been a steady increase in the SVMH, NMC, and Me Memorial APOT times, except for in September, where SVMH had a 19% decrease. Times decreased across the board in September, but SVMH had the largest decrease. According to the data, CHOMPS times have decreased April through December in comparison to 2019, which is great considering the challenges with COVID. March was the only month with a significant increase. And you can go to the next slide. The actions in progress. The field crews are advising AMR dispatch when held at the hospital due to APOT. AMR dispatch is logging this information into the CAD and relaying it to the field supervisors, so they're aware of a significant delay and can act accordingly. And we're working with AMR to establish more specific guidelines to address increase in APOT times. Anyone have any questions or comments?
Hello, this is Scott Houchin again. I just want to commend the hospitals on doing a great job. APOT times with our neighbors are significantly longer. So I think our times are very reasonable, and I think the hospital's done an incredible job getting people into admissions.
I'd second that, and I also would like to thank everyone for continuing to work as a team during the course of the pandemic. I know there's been many challenges, but everyone has stepped up and really made the best out of a difficult situation. So thank you, everyone, for keeping the system running smoothly and taking care of our patients.
We have a question from Tino Arellano.
Okay.
He says, does the APOT in time include all ambulance services in the county, including fire deaths?
And the fire department?
Can you repeat the question?
Does the APOT time include all ambulance services in the county, including fire department?
The data that I ran on AMR's APOT times, but I can run the information with all service providers.
Any further discussion? Okay, thank you, Kimberly. And that brings us to future agenda items. It's an opportunity for members of the committee to bring agenda items for future discussion at the next MAC meeting. Hearing no specific future agenda items, I'll move on to general announcements and good of the order. Any member of the committee may make announcements or comments. I'll announce that I had my my second COVID shot through Pfizer on Monday, and although my arm is a little sore, it went well, and the process seems to be moving, although not as quickly as you know we might hope. It seems to be moving well, and I'm excited by the fact that we're at this stage of the game where we can start fighting back. So for those that want their vaccines, I strongly encourage it. The other thing I'll announce is that just from a personal level, not everyone knows this, but I write books, and so yesterday was the release date of my 4th novel. I write under a slightly different version of the last spelling of my last name to keep it simple, and so I was excited and happy to get to the end of that long journey of work. So that came out yesterday.
Congratulations.
Thanks.
Yeah, it's awesome.
So that, I think, is any other announcements or comments?
I just wanted to thank all of the first responders, all the EMS providers, and everybody for being patient with the situation. I know even at Natividad right now, we're into our 3rd outdoor tent, and we have had inpatient boarders throughout the ER, psychiatric boarders throughout the ER, even over into our interventional radiology waiting room. And so I know the APOT times are a little on the high side, but considering how bad the COVID situation is in Monterey County and all the hospitals, thank you guys and gals all for continuing to do the work you do day and night. And keep it up.
I agree. Thank you from Chomp too. And thanks for helping with all those interfacility transfers you guys do.
Yeah.
Great. Well, thank you all for hanging in there for a long meeting. And, you know, I think this is important work. And so thank you all for the public comments and for bringing questions and concerns to the agency. We truly value your comments and input, and we enjoy working with you in a collaborative fashion to, you know, continue to move forward and have a progressive, effective EMS system. So we'll go ahead and conclude our meeting. The next meeting date is going to be Wednesday, March 10th of this year at 8:30 a.m. And more information regarding where we'll be having the meeting will follow. And unless there's anything else, we can go ahead and adjourn the meeting. Thank you again. And we'll look forward to seeing you at EMCC.
Thank you all.
Thank you all.